Hi, my name is Stephanie Twist. I'm with A&MS, and I'm here with Dr. Kenneth Cook. We're going to talk to you today about gastroparesis. And Dr. Cook, I'll go ahead and let you take the reins for this. And welcome to all of our guests who have come today.
Yes, thank you. Thank you, Stephanie, and welcome everybody. I'm delighted you're taking some time to um, be with us this afternoon for 1 hour or so. You can see that the topic is gastroparesis. I'm going to review much of what we know about gastroparesis with some updates that I hope you'll all learn something about the way we think about gastroparesis and treat it these days. So without further ado, let's go to the slides. Um, First, we always have to talk about disclosures, so that's my disclosure slide. We're going to talk today about symptoms of gastroparesis, particularly nausea. It's been a special interest of mine. What causes nausea, pathophysiology of nausea, and pathophysiology of the stomach. I want to talk about how the stomach works as a muscle, and then what goes wrong in gastroparesis. In diagnosis, we're going to talk mainly about gastric emptying and the gastric electrical activity. And the treatments, diet, drugs, and devices is how I divide this up. And so we're going to take about 30, 35 minutes to go over this, and then I'm going to be looking for your questions about this material. So I'd like to think about symptoms associated with gastroparesis, and you all know these symptoms: nausea, vomiting, early satiety or fullness, abdominal discomfort, and pain. And we like to attribute those symptoms to the stomach, but it's kind of dangerous to do that because those are nonspecific symptoms. But in terms of the stomach, we do attribute them if you have delayed gastric emptying. But as you know, there are many people who have normal gastric emptying, and we're beginning to call them the label, if you will, the diagnosis chronic unexplained nausea and vomiting, or CUNV. Some people call it functional dyspepsia. Uh, some people call it postprandial distress. There's a bit of difficulty there. But some people actually have rapid gastric emptying or dumping syndrome, and they can all have these symptoms that are associated with gastroparesis. But what I really like to do when I see patients is, have I identified the organ that is really driving the symptoms? Because I do worry about the esophagus. And is there atypical GERD that's actually causing the nausea? Could it be the small bowel? And SIBO is small intestine bacterial overgrowth. Could the symptoms be caused by the colon, like IBS? What about the gallbladder? Could it be causing some of these symptoms? And some patients have several or all of these. So the whole approach to treating gastroparesis is to be sure you've identified the stomach as the main culprit, the main organ driving the symptoms. So nausea is one of the most common and actually, I think, most debilitating of symptoms of all those that we associate with gastroparesis. And nobody but the patient seems to necessarily understand that unrelenting nausea results. You get depressed, and it wears one out. And I've heard over and over that people tell me I don't have a life anymore, and it took me a while to understand what they really meant by this. But as you know, the loss of social support and the pleasure of simply eating and dining with family and friends is really a huge loss of what gives quality to one's life. So nausea is a huge symptom, and it's often difficult to describe. The physician doesn't always exactly get it, what we're trying to say. And I've had patients that I have finally said, well, where is your nausea? And this is what I've come up with. And I show all my patients this diagram, and I call it a nausea locator, and it helps me. And I describe this figure. I ask the patient to consider a map of their body with the head, the neck. You can see the chest is outlined. I show the belly button, was halfway down the abdomen, the groin, arms and legs, and I say, where is your nausea? And I've been very surprised over the years in using this. And you might ask yourself that question too. Where is my nausea? Because I worked with this patient a long time trying to figure out their nausea. And this is where they said their nausea was located. Really? That's that's nausea in the chest. That's not even in the abdomen. And this patient we eventually found had atypical acid reflux symptoms. Their nausea was actually in their chest due to reflux. This patient and many others have did an absolute beautiful circle around the umbilicus. It looks like a bullseye. And in these patients, we frequently found SIBO, or bacterial overgrowth. What about this patient? There, they circled an area right in the epigastrium. That's where the stomach should be. The transverse colon is there, and the gallbladder sometimes has symptoms in those areas. But these simple diagrams help organize my thoughts and my diagnostic workup in many patients. So when we looked at 197 patients, then they filled this out, you see about a third of the patients said my nausea is in the epigastrium and chest together, about another third. And then you can see the percentages of around the belly button, chest only. And look at the head. You know, nausea is not in the head. 1% of my patients circled like their head, and they had migraine headaches and other problems like that. So it's very interesting, and perhaps you'll think about describing your nausea in terms of location as well. Well, what about the stomach? I want to talk about the working stomach, the physiology of the working stomach, and then when it sort of becomes abnormal. So our stomach starts to work at mealtime, and the sort of names I'd like you to think about is the work the stomach does is accommodating the food. That means it relaxes first to receive the food. It is a triturating action. Triturating is a fancy word for mixing and milling solid food. Like corn is milled to become cornmeal. And then finally, the emptying. When the stomach has milled our food into fine particles, then there are peristaltic waves that further empty our food. So the work is accommodating, triturating, and emptying. And the next slide sort of shows this in a pictorial form. You can see where the top of the stomach is called the fundus, and as solid food comes in, the fundus relaxes to receive. You can see the fundus empties into the corpus, and there is the mixing chamber, the corpus, and the antrum. This is where the food is triturated or milled. And then with peristaltic waves, the tiny amounts of food are emptied through that pylorus. You see where it says pyloric resistance. So each peristaltic wave comes down the stomach, the pylorus empties to a degree, and a amount of this milled food, it's called chyme, is emptied into the duodenum. And this happens over and over and over to empty our food. It requires some antroduodenal coordination. This is a very important physiology. This is because this is how we obtain our nutrition. It's extremely important, and that's why these contractions are paced. The stomach has a pacemaker rhythm. It's got a pacemaker region. It's outlined there between the fundus and the body. And from that area are generated slow waves, also called pace setter potentials. So those mixing and emptying contractions of the stomach are paced, and they move from the corpus down into the towards the pylorus at 3 cycles per minute. And we've been interested for years in measuring those electrical waves. They're called electrogastrograms, and electrogastrograms are the gastric myoelectrical activity recorded from the surface electrodes, much like an EKG looks at electrical activity from the heart. So when there's food in the stomach, there's more activity, there's more peristaltic contractions required to do the work of milling and emptying, and we generally see higher amplitude of electrical activity at the normal 3 cycle per minute rhythm from the stomach. So to get those good contractions, you need these electrical events. And now we know over the last number of years, with some research that's been driven by several centers, including the NIH Gastroparesis Research Consortium, that the pacemaker cells are identified. They're called interstitial cells of Koch, and when they're depleted in humans, and this has been shown in a number of animal species, when those cells are depleted, we get delayed gastric emptying, we get gastroparesis, and many patients with gastroparesis have obvious depletion of those cells. And if you use very fancy microscopes, you can find some tiny damage in almost all patients who have gastroparesis. So we think that one of the key problems are these pacemaker cells, and once you lose the pacemaker cells, then you begin to develop dysrhythmias, gastric electrical dysrhythmias. That's now been shown by several centers that when you look at tissue from healthy subjects, they're going to have 5.5 ICCs per high power field, but the gastroparetic patients average about 2.3. And when you have enough ICCs, you have good numbers of ICCs, you're in the normal 3 cycle per minute rhythm. When these ICCs become depleted, you have a variety of gastric dysrhythmias, tachygastrias, bradygastrias, mixtures of those, and you can see it becomes a very electrical menu of diagnoses there, much like in cardiology. So those ICCs are very important for the stomach, and we can measure them by putting electrodes on the surface. You see the stomach below those electrodes, and we look for those electrical rhythms from the stomach that can be recorded by the surface electrodes. So this is a sort of a fancy slide, but if you look at those EGG rhythm strips, and you look at the 1 minute designation at the bottom, you can see some very strong 1, 2, 3 cycle per minute waves. We make the stomach work by having patients drink water till they're completely full. They have 5 minutes to drink till they're completely full. This was a healthy subject, and they drank almost 700 ml of water in that 5 minutes. And if you look at the electrogastrogram in the panel above, there are more regular and even stronger 3 cycle per minute waves. So that's the rhythm strip, but that rhythm strip can be digitized, just like you have digitized music. We digitize this signal, and in the long frequency CPM line at the bottom of the screen, you look at the 3 cycle per minute frequency, and you can see that after this subject drank water, they have a very nice regular set of 3 cycle per minute peaks. So this looks at 30 minutes of that signal, but it summarizes it, and you can see as a frequency analysis, there's lots of 3 cycle per minute peaks, and they fall within the normal frequency range. The bad frequencies are too slow, bradygastria, and too fast, which is tachygastria. So keep in mind this very nice normal rhythm, and then tell me what you think about that rhythm. Wow, that rhythm, if you look at 7 to 8 minute, it's like a fibrillation. There's like 7 or 8 waves per minute. We recorded this from a college student who'd gotten the flu her freshman year and developed nausea and vomiting. Most of her doctors thought she had developed bulimia or some sort of college-related stress problem. They were totally wrong. I mean, there's a dysrhythmia here. This patient, we documented severe gastroparesis. The real diagnosis was post-viral gastroparesis. And look at her electrical, we call it an RSA, but you can see at 3 cycle per minute, there's a few peaks, especially right after the water, but the most of the peaks are in that 7 to 8 cycle per minute dysrhythmia. So that would suggest that those interstitial cells of Koch really got depleted during that particular injury, most likely viral. So that's her. So this is getting to this bit of a new area where we want to subtype gastroparesis. They're not all the same. Not all gastroparesis injuries are the same. So B shows the young woman EGG and running spectral analysis I just showed you with the bad gastric dysrhythmia. But panel A is also a patient who has gastroparesis. But look at those electrical waves. They're high amplitude. They look like 3 cycles per minute, and they are. The running spectral analysis, if you look at the 3 cycles, they're peaks up and down, very rigid 3 cycle per minute peaks. In fact, I had this patient, and we published on about 10 patients like this a number of years ago, because when I went down to look at this patient endoscopy, the pylorus was so tight I could not get my scope through it. The pylorus was stenotic. This is a mechanical obstruction. I guess it had been missed, but in any case, what I found was obstruction. So you see, that obstruction was at the pylorus. And that led me to believe that this particular pattern suggested pyloric problem. Well, these people had to go to surgery to have those stenoses fixed. But I see many other patients like this one who has a nice 3 cycle per minute pattern. This was a diabetic patient with gastroparesis. But I scoped this patient, and you see I could get my endoscope through the pylorus. It was not obstructed. So what's the problem here? Well, this is where we begin to think about, well, maybe they have pylorospasm. There's a problem with the pylorus, but they have a good rhythm, suggesting there's plenty of ICCs, there's good contractions, but the pylorus is the point of a functional or neuromuscular obstruction because of the pylorus. And so this is where we are now. We are trying to improve the precision of those diagnoses for gastroparesis. We combine the emptying result and the electrical result that's in response to a water load satiety test. And this is what we tend to find. So when I have a patient with unexplained nausea and vomiting, I have a big differential diagnosis. I want to exclude that there's not the gallbladder, it's not the small bowel, it's not irritable. I want to exclude those other problems so I can focus on the stomach as driving most of the symptoms. So if the patient has gastroparesis, we want to see what the electrical rhythm is. And it turns out about 80% of my patients have a dysrhythmia, and 20% have that normal rhythm, which is very important because we're beginning to adjust our therapy for those patients and look more to the pylorus. Is this a pylorus? Is this gastroparesis being driven by pyloric problems? Is it spasm? Is it mechanical? But with endoscopy, we can rule out those mechanical types of obstruction. So that's the general way we're going with this. And so that subtyping, just to show it another way, whether you're diabetic, gastroparesis, or idiopathic gastroparesis, post-surgical, we really want to know, in addition, is there a rhythm problem? A dysrhythmia, which is probably more common, but if we can find that nice normal rhythm in somebody who has a delay, that does lead us towards these other types of treatment for the pylorus. So let's talk a little bit about treatment. I'll summarize some ideas here and then take some questions. So I think of treatments in terms of keeping up good nutrition, addressing the key symptoms, and trying to adjust my therapies towards the pathophysiology that we are finding with the stomach. So that's diet, drugs, and devices. Well, a diet, I don't think enough time is spent with this. I spend a lot of time with my patients because I'm trying to help them understand they have to fit their food choices to the weakness of the work that their stomachs can perform. Whether it's a problem of accommodation, mixing, emptying. I'll show you the diet that we go over to some degree. It's very important. It's probably as good as most of the medicines we have right now. And as you know, in terms of drugs, we have a very poor assortment of drugs to pick from. And we need much, much more action in this area. Um, so they really come down to pro-motility drugs, drugs that are going to try to help the stomach empty stronger, empty a little more rapidly, and anti-nausea drugs. Um, and I'll go over some of the ones I use. We use these empirically. They're sort of cover-ups. They don't get to the precise mechanism of nausea necessarily. And then for drugs, we do have a few drugs. Well, one drug for the pylorus. It's Botox, and um, many of you perhaps have had Botox injections in the pylorus. We use it for this obstructive form of gastroparesis. Devices. So the devices I've broken down here. There's devices to work on the pylorus. If it's in spasm, it doesn't distend. We can put a balloon in there and dilate. And then what is becoming a very intense area is the so-called GPOM, or it's really a peroral endoscopic myotomy of the pylorus. The pylorus is cut endoscopically. And the other is a surgical pyloroplasty. There are several types of pyloroplasties. They've been around for many years. It's a standard surgical operation. And then for the stomach in general, there's gastric electrical stimulation that's available as well for recalcitrant or refractory nausea and vomiting. So let's look at these a little bit more detail. This is a diet I go over. It's in every chapter I've ever published, I think. It's what I hand out in the clinic. It's kind of a short version. Dietitians expand on this. It's not a complete diet, but I think it fits with the pathophysiology of a very weak stomach. If you look at step 1, step 2, step 3. Okay, step 1. In step 1, Gatorade and bouillon, we're just trying to keep the patient hydrated so they don't have to go to the ED or the infusion center for, IV fluid. And it has to have electrolytes in it. Patients will tell me, but I drink a lot of water. Well, water doesn't do anything. If you're dehydrated, you need salt, potassium, and water. And Gatorade and bouillon begin to get there. I don't like to use citric, avoid, citric drinks because a lot of patients have heartburn. Often they're on an acid suppressing agent. Why give acid? Why take acid in your foods? But patients who are doing better than that, they're keeping their Gatorade down, can go to step 2, which is soups, and it could be soups and smoothies. Soups and smoothies, they're nutrients, but they're already triturated. They're already milled. And your favorite chicken noodle soup might be an idea here, or chicken with stars. It's very light, it's salty, and a weak stomach may be able to empty that. Look what I have there to avoid. Creamy. This is not cream of onion soup or cream of mushroom soup. This is not milk-based, but the lighter soups. When that's tolerated, folks go to step 3. The solid foods. Everybody wants to eat a solid food, but if the stomach is weak and it can't triturate, it's got a dysrhythmia, then the starches are much easier to empty for a stomach than proteins, than fat, let alone undigestible fibers. So the foods to avoid here are the fried fatty foods, the red meat, which can be tough, fresh vegetables. How's the stomach that's got gastroparesis going to mill a cucumber or a raw carrot? They can be cooked till they're really, really mushy, but those are problem foods for the work of the stomach. And so that's why we emphasize, small bits of chicken, fish, and the starches. And a one-a-day vitamin is important because this is not a complete diet by any means, but may help patients get through their days by adjusting the diet to the weakness of the stomach. Okay, that's a very important first step because the drugs are not that great. And so it's important the patient understands their stomach, how it works. And so I'm sure you won't forget your stomach has to accommodate, mix, and then empty. So we have drugs that are just trying to help it empty, basically. And that's the old metoclopramide, which I stop it more often than I start it. Erythromycin may help some people, but it's got side effects. Mestinon is a neurological drug and helps release acetylcholine, may promote some gastric emptying. No super great trials on any of these medications. Some of you probably get domperidone. It's a very nice drug for nausea, but it's not approved in the States. And then one of the drugs that's under trials right now is a ghrelin agonist. It's a hormone in the stomach, but its name is relomorelin, under trials for diabetics with gastroparesis, and so we'll see how that goes. But we don't have very many drugs, and that's why the diet's so important. And then trying to help with nausea. And I just list some, I just walk through them because we don't know exactly what's driving the nausea. But Zofran is a serotonin antagonist. Marinol was designed for cancer chemotherapy drugs, and it is a marijuana type drug without the CNS effects. Elavil, Ativan, Amen. These are just some drugs, and you may have tried other ones yourselves that work because we don't really know which one to try. We'll try them all sequentially if needed. So other therapies now that are exciting, especially when I see patients who have that obstructive 3 cycle per minute rhythm and gastroparesis, we can look to the pylorus. And so we put Botox injections in there. I may put a balloon in there and try to stretch that tight pylorus all the way to what you're probably reading more and more about is either GPOM or a surgical pyloroplasty or pyloromyotomy. And so here's what we do if you're getting into that category 2. How do we, that's first of all a way that we get to thinking about pyloric therapy. So first of all, you have to have gastroparesis, and that means it's the 4-hour egg beaters gastric emptying study. That's still the standard. I still see, tests that aren't done properly, and it's got to be a proper 4-hour gastric emptying study. You've got the 3 cycle per minute rhythm. You've had endoscopy, which shows there's no obstruction, there's no fixed stenosis at the pylorus. There's a device called the EndoFlip, which we can now go with the scope. When the patient's asleep, it actually measures distensibility of that pylorus. So we're getting more data about the pylorus distensibility spasm, if you will. Usually when I'm seeing folks at this point, they've failed medical therapy. Nothing's really working that great. And we double check that something hasn't been overlooked that could be driving the symptoms. So we keep an open mind. It might not just be the stomach, but with all those things taken care of, you see, then it makes sense physiologically to me to go ahead and, like the panel on the right, injecting Botox around the pylorus, which is in the distance there. And the panel on the left shows a balloon in the pylorus, and we're stretching it. So the Botox relaxes the sphincter, the pyloric sphincter, and the balloon idea is to stretch those muscle fibers so it's not so tight, and will let food empty a little better. Well, we looked at some 33 of our patients like this with the functional obstructive gastroparesis, and look at their percent. The average was 42% of the meal retained at 4 hours. So normal food retained by the 4-hour gastric emptying is 0 to 9%. These patients averaged 42%. So they were of the severe gastroparesis. and we did Botox or balloon on them, and overall there was a 78% of the patients reported improvement in symptoms. They gained weight, and so that was very good. Now, it was not a double-blind placebo-controlled trial, so there's certainly more work needs to be done to um, look at this, but we thought it was very effective in this particular clinical setting. What about going on for a pyloroplasty or a GPOM? So at our at our institution, or what I like to see is that the patient actually says after 2 or more endoscopic therapies with Botox or balloon, that the patient and their family, whoever, they all agree, gee, that really helped. The patient was really good for 1 month, 3 months, 6 months, and then the symptoms tend to come back. And then we repeat it and we see if we have a good response again. So some patients want to just keep doing that. Because if you're thinking about surgery, there's also risk. There's any risk of surgery, but there's also that with the pylorus, cut, basically destroyed, there's a chance of emptying too fast or having dumping syndrome. So we're very careful about considering this, but some people have done extremely well with the Botox and balloon, and those are temporary treatments. They really aren't durable in most people. And so we've had about 10 patients who wanted to do a pyloroplasty. And this graph shows at the baseline, after 4 hours, those are the amount of food remained in the stomach with the egg beaters test meal. And to the right, it says 6 months after they had a pyloroplasty by our surgeons, this is what was remaining in their stomach. And so, 6 of these patients actually became normal emptiers. They felt their symptoms were much improved. The one that didn't improve much at all was diabetic, and so there may have been other issues going on besides the pylorus, but that one did not respond so well. But it gives you an idea that in these patients working on the pylorus with actually sphincterotomy did improve their gastric emptying, and again brings home the point that the pylorus is a important a part of gastric emptying. So my take-home messages. So the diagnostic test to determine what organ or organs are driving the symptoms, very important. It may not be just the stomach. When it is the stomach, we have the gastric emptying studies, we have the electrical studies to help determine the subtypes of gastroparesis. That's where we are now. We want to consider the proper diet, the drugs that we have. We've got stimulators for gastroparesis with the implantable electrodes on the stomach. And I think that if there's a dysrhythmia, that's the way to go at this point. Now, we need better studies. We need controlled studies, but the endoscopic pyloric therapies for gastroparesis with the normal rhythm, we can do that safely endoscopically. When you get into the GPOMs and the surgical pyloroplasties, we have to be careful. We also need studies there to look at the risk and the downstream incidence of dumping. These are not available. But I do believe that more developments, in drugs and devices will advance as we learn more about the diversity of neuromuscular abnormalities in gastroparesis. So those are kind of my slide remarks. I'm happy to entertain questions,
We've been getting a lot
Stephanie.
All right, so I'm going to go ahead and present some of the questions that have been coming in. So first one is for patients who are, yep. For patients who are looking for a list of a diet or recipes or where they can find a list of really good foods for patients to take, because I know that you had presented on it earlier.
Yeah. Well, I've been meaning to write for 10 years a cookbook. And the cookbook is spelled Kochbook. That cookbook is not available. But there are cookbooks out there for gastroparesis patients. There are several. Most patients can ask their doctors, is there a nutritionist, a dietitian in the area who can help with these diets? Hopefully, there's some resource like that. So, you know, it's, and then each patient sort of has to figure out for themselves what stays down. And I say, if a certain food sits well, you're comfortable, man, that food stays on the menu and you build on that. So a lot of it is still trial and error, uh, but I hope those comments help you find some additional resources.
And we had another question in that was, could you tell them the difference between a G poem and a POP procedure?
POP?
Hmm.
Not sure that I know what a POP procedure is. There, and maybe the person knows what the POP stands for. So there's been a couple, though, technical things for the pylorus. One is putting in a stent, an actual metal stent or plastic stent through the pylorus, just to hold it open. And there was mixed kind of response. Unfortunately, the stent tended to migrate, and so it'd go downstream, it'd go back in the stomach. But again, the idea was, at least temporarily, the stent held the pylorus open. Now, the GPOMS is an endoscopic technique where through the scope, um, and most of you have had endoscopy, so it's an endoscope, but the lining of the stomach is opened up, and a special sort of, they call it sphincteratome, is used to cut the muscle of the pylorus, and it can be done endoscopically. Then that incision, if you will, is tightened back up with different kinds of clips. So there's increasing research coming out about this particular approach, and it tends to be positive. So I think patients will be hearing more about GPOMs.
Okay. Another question that came in is, do you recommend any multivitamins for pediatrics with mild gastroparesis?
Well, I think, mild to moderate to severe gastroparesis, it has been shown that the symptoms can be very much the same regardless how slow the stomach is. So those symptoms of nausea really tend to limit what we want to eat. So for all ages, and for kids will like this, but I tell I say to my adult patients, don't you like the Flintstones? Do you like Fred? Do you like Wilma? He said, you should just get yourself a gummy Flintstone. And then you suck on that vitamin. It's not hard on your stomach. There's no work. It's not a horse pill. And every day they get all their vitamins, despite the restricted diet that I described. They get all their diets. They should all be taking that Flintstone type gummy vitamin.
Okay. Another question that came in are, what are your suggestions on pain relief due to gastroparesis?
That's a great question because I think that's a serious issue. Because if your stomach is weak, where's the pain coming from? And so it can come from pylorospasm. And that pylorus tends to be over in the middle to the right upper quadrant. And you can have pylorospasm and it's fooling everybody to thinking it's gallbladder. Or maybe the pain is from the gallbladder. I've had patients who have both gallbladder pain and gastroparesis. So when there's pain, I my approach is find out the cause of the pain first. Because if you can detect and figure out what's driving the pain, you can often figure out, it may be what's driving the nausea. So if your pain is coming on first and then the nausea, um, you need to find the source of the pain. It could be irritable bowel. It could be a lot of different things. Okay. I have patients who have nausea and vomiting and then they get pain. And sometimes that's That's the pain of the retching. The muscles of the abdominal wall are hurting. And finally, just so this is not a simple question, I have many patients who have had their gallbladders out, they have gastroparesis, and they have a pain syndrome. And the pain, if you examine properly, the pain is in one of the old scars. The pain is actually in the scar. And so that's a very local pain. You can put your finger on it. And so the pain question is a big one. And you have to sort that out. It's a whole nother thing. You have to sort out where that pain's coming from, and don't necessarily blame it on the stomach.
Okay, kind of going on a similar tangent. They want to know, another comment came in on any information and or hope for surgical gastroparesis with dense adhesions.
Surgical gastroparesis, meaning it came on after surgery?
Uh,
Surgical gastroparesis.
I believe surgically caused, I
Yeah,
believe, what they're
so
trying to apply.
there are some. The most common surgery that can have a side effect of gastroparesis is the Nissen fundoplication. Many patients have severe reflux and GERD. They don't respond to medications. They get the Nissen fundoplication for that reflux, and that operation deforms the fundus, so you don't get good accommodation, remember. But while they're up there near the esophagus and stomach, the vagus nerve can be damaged. And with damaging the vagus nerve, that can relate to delayed gastric emptying. So there's always adhesions when that surgery is done. That's one, and so one needs to go through the workup that I sort of described to try to figure out, is that an obstructive kind of gastroparesis or not. So that's the most common. The other forms of post-surgical gastroparesis are when the surgeon, because there's an ulcer that won't heal, there's a cancer in that antral area, which I pointed out. Well, now you have to remove a super important part of the stomach. And those operations are called Billroth 1 or Billroth 2, and they can leave patients with a post-surgical gastroparesis. So these are some of the hardest gastroparesis patients to, treat. I must say they're very difficult, but we go through the same workup and try to understand both the emptying and the rhythm and go from there.
Okay. We're getting a lot of good questions coming in.
Excellent. You mean somebody was listening?
Oh, we've had a pretty good response so far.
All right.
So one of the questions is, what do doctors believe is behind the rise of gastroparesis in teen girls and young women?
Well, I think gastroparesis has always affected women. In our NIH groups and other groups, it's always like 80% women. It is a women's disease. We've done a very poor job of figuring out the gender differences there. And so many of my patients are as an adult gastro, they are in the 18 to 30 group. It doesn't tend to occur so much in the very elderly women, but so that's an unknown. I hope it's being diagnosed more because physicians are more aware that there is such a thing as a neuromuscular disease of the stomach that presents with nausea, early satiety, and guess what? The endoscopy is normal. It's not a mucosal problem. Uh, it's not an acid problem. And so I think perhaps I would hope there's a little more recognition of it. I don't know that it's actually, occurring more in our country. I hope it's more recognition.
Okay. Another question that came in was, Remelin was mentioned, but what are your thoughts on the drug Velstrag in clinical trials?
The relamorelin drug I mentioned. Yeah, so it's got a different mechanism of action. It's a prokinetic. It does increase gastric emptying, and it seems safe. It doesn't have any EKG type problems. It's safe. So it just needs to go through the trials. It is being identified for diabetic patients, but if it gets approved for diabetic gastroparesis, physicians are able to prescribe that in non-diabetic patients. Although there is not the strict data on it, so I'm optimistic that will be helpful for many of our patients.
Okay. I had one come in that says they're curious to know if gastroparesis has um, any part in regulating body temperature, if having the diagnosis
Mm,
also correlates with that.
that's an interesting question. Um, in so first of all, we don't know for sure, but I that it has a straightforward. But I'll give you this kind of idea. We love to drink cold drinks, and they go directly to the stomach, and it's the stomach's job actually to warm them up. The stomach actually stops contracting. It actually doesn't move for a while. It won't empty an ice cold beverage into the delicate small bowel. It does hold and warm. So it's an interesting question. So to that regard, if your stomach wasn't working right, might there be a trouble with that uh, uh, temperature elevation, of what we drink? I sometimes do tell patients, however, whose stomachs don't relax very well. I say, why are you drinking cold? Something warm might relax the stomach a little more than something very cold. So anyway, that's an interesting question about temperature of what we swallow. Um, and how the stomach has to deal with that, um, and body temperature overall control. Um, the only other scenario might be we're also finding more patients with autonomic nervous system problems and gastroparesis. So some of you may have POTS, postural orthostatic tachycardia syndrome, which is an autonomic nervous system problem, and we're finding that problem in a fair number of patients who have gastroparesis. And in that regard, autonomic nervous system may also play a role with body temperature, cardiac events, stomach events.
Okay. Um, is there a way to determine if one has dumping syndrome after G-poem?
Yes, um, we, as I mentioned, when you have these symptoms of nausea, vomiting, abdominal discomfort, and so on after we eat, we have patients who eat the standard egg beaters meal, and after 1 hour, they have 30% retained in their stomach at 1 hour. That means 70% got out in 1 hour. And by the old study, the kind of study that we still depend upon, that's considered rapid emptying. So if somebody had a GPOMS or a surgical pyloromyotomy and weren't doing well, uh, one approach would be, of course, you look down there to make sure they're not strictured, they're not fibrosed down, a surgical complication. Um, or if it's wide open, you could consider a 4-hour gastric emptying study and see you could actually prove that the um, stomach is now dumping the meal, where before that it was holding on to the meal. You've switched from gastroparesis to dumping syndrome. Um, I, and as I said, there can be idiopathic dumping syndrome. This is another thing why you need to do the test to figure out just what's going on with the stomach, because you can have dumping syndrome just without any operation on your stomach.
We had another question come in that said, what else can be done if you've already tried medications, Botox, pyloroplasty, and the gastric pacemaker?
Wow. You mean like you had all those things? Well, if somebody kind of escalated all the way through those things, including the more invasive things, um, and you still have symptoms, then two things. I would do the gastric emptying and the electrogastrogram to see what are we left with after. Do we have rapid emptying? Do we have dumping now? Uh, what is the stomach doing? And the other is, it's probably been done, but you go back and review the symptoms. Is there something else driving the symptoms? Let me give you an example. I had a patient who really um, was one of my patients who did have the pyloroplasty, and they were eating better to an extent, but they still had pain. Well, this patient still had, we found those scar tissue, scars in the cholecystectomy trocar sites. So she's gone to pain clinic to get those scars remedied, decrease the pain. But she also still has severe irritable bowel. And she has GERD. So in some patients, it's more than just the stomach. And so this patient could go back and review with their doctor what let's talk about my symptoms again, because is something else driving these symptoms? Because we did what we could with the stomach. I call it, have you heard the term barking up the wrong tree? I would, maybe somebody has heard that, but you can be so focused on barking up one tree that, the real problem is actually two trees over. And so um, that's what I'm getting at when the stomach's been worked on. Maybe it is IBS, or it's their GERD, or it's it's some other problem.
Okay. We had another question come in. So they want to know what is the current knowledge on reverse peristalsis as well as duodenal gastroreflux. She wanted to know if it's a separate problem or if it's linked to gastroparesis somehow.
Yes. Well, so we didn't get into that too much, but um, remember, beyond the pylorus begins the duodenum. And when people vomit, the body actually does a reverse peristalsis. The duodenum goes into reverse. It brings up, poisons or pills or food. It puts it in the stomach. The stomach and any food remaining is vomited. So nature has a reverse peristalsis, but that's like a normal reflex when, for instance, people have ingested inadvertently a poison, and I think in patients who have gastroparesis, it is everything is off. The body feels there's a problem, there's sickness. So there is reverse peristalsis during a vomiting episode, um, but I think that's just the body responding to severe nausea. We don't really want to mess with that. We don't want to touch that. Sometimes you have to vomit, and people may feel better temporarily, but that's such an primitive reflex that's going to be hard to stop that reverse peristalsis of vomiting.
Okay, we had, speaking of, again on the same tangent, we had a question come in. What would you suggest if a patient does not throw up? And maybe they have additional gallbladder issues. Like, what would they do if they continue to have nausea but they don't throw up?
Yeah, but many people don't. They tell me they don't throw up. They can be nauseated up to here, but the way they're wired, their body, they don't throw up. And some people also just truly fight throwing up. They just don't want to throw up, and who would? So to me, you don't have to have vomiting. I think many people learn how to eat, so they intuitively know to put lesser amounts in their stomach. They get nauseated, they get full, they're uncomfortable, but they figure out how not to vomit. And so they still have gastroparesis. You don't have to vomit to have gastroparesis. If you're vomiting, chewed food, that's a good sign for the doctor. Doctor should know that, but you don't have to be vomiting, and you can still have plenty of gastroparesis.
Okay. We had a question come in, benzodiazepines. Can that be used to regulate vagal tone and promote motility and help with pain?
Well, we don't know of any motility effects per se with the benzodiazepines, but um, I'll tell you, some of my patients tell me, they have sort of a nervous nausea. They're just, these are horrible symptoms. Some people, uh, many are depressed, some are nervous about it. And I sometimes use Ativan, for for nausea and nervousness. And sometimes that's just what patient needed. It will take care of the nausea. I don't know how it's working. It may be more centrally. I don't know that it corrects a rhythm or does anything with the stomach, but I've certainly seen it work.
Okay. Does Phenergan slow down gastric emptying?
Again, never studied. A lot of these old drugs, I still have a lot of patients, that's the only medicine that helps their nausea. It makes them drowsy, so they get on the smallest dose they can. Um, Once again, actual mechanism we think is probably central, but we just don't know if these same drugs have an effect on the stomach per se, as well as in the brain. But lots of folks still find it helps their nausea.
Okay. There's just a lot of questions coming in. I'm just trying to make sure I get everybody's.
Well, I think you said we were going till 6 p.m. No, we're not going to 6 p.m. So,
All right. So
well,
I
right.
guess we'll.
Well, no, continue. I
Okay.
think we're good. We were going to. These are great questions, by the way, and I'm happy to. I think we were on till 1 or something.
Okay. One of the questions: are there any benefits from taking IVIG therapy?
Uh, at this point in time, I don't know of any scientific studies or any rationale at this point. Um, but doesn't mean to say. But in the future, perhaps we do think that some of these ICCs that are lost are maybe due to a certain kind of slow inflammation. Uh, there's macrophages, which are very funny white cells in the stomach, and they may be bothering the ICCs. But at this point, we don't we don't recommend those sorts of infusions uh, for general standard care.
Okay. And we had a follow-up question to one that you had already addressed. If someone does have the G poem procedure, how likely is it that they would develop dumping syndrome as a result of the surgery?
Yeah. So I don't think we know the answer to that. I think most studies go out 3 months. It should be noticeable by then, or 6 months. I think it'll be a small number. But when people have dumping, they don't like it. I just think it's good to be aware that when you cut a sphincter, there can be a problem with the rate of outflow. So I think that's what we need to have more reporting on longer term outcomes, that the right patients are selected for the best results, and so on.
Okay, we got a final question before we end for today. What would cause bile to continue to build up in a person's stomach even after a pyloraplasty?
Okay, good question. So here's the thing. Um, all of us get a little bit of bile reflux from the duodenum every day. And there's some thought that bile helps that mixing uh, events I mentioned. We have fat in the stomach with our meal, that bile is helpful. But the pylorus kind of regulates that. The pylorus regulates to a bit how much bile backflows. So now if you cut the pylorus, there is no regulation of the bile backflow, and in some patients, they could have more than is normal. So that's a very good point, and maybe that's something we'll be looking at in the future when somebody's not doing so well after pyloroplasty, and you look in the stomach, and now there's bile everywhere. Well, the pylorus, was a sphincter that kind of regulated that. So that's a good point, and something that I'm sure will be looked at going forward.
Awesome. Well, thank you so much for taking the time to speak with us today. We had really good questions and a lot of really good answers.
Well, I want to thank you, Stephanie, for getting this organized, and the ANMS. I've been a member. I don't want to tell you how many decades I've been a member, and I really appreciate the invitation to talk today.
All right, wonderful. Well, thank you. We'll,
Thank
guys,
you.
let you know when we have the next Facebook Live event. Have a great day.
Thank you, everybody.